Recording has been started.
Taylor. Yes, ma'am. Yes, ma'am. Thank you. Okay, good evening, everyone. I'm Yashoda, and I welcome you all in this national level online webinar series organized by the International Longevity Center India with the CSR support of Gharda Chemicals Ltd. We at ILC India always try to find experts from the different fields so that we can introduce new and crucial topics to the audience. Today we have with us Dr. Prem Narasimhan sir. He's going to talk about the topic called orthogeriatrics. Now let me introduce him to you and then we will begin the session. Dr. Narasimhan is Chief Consultant and founder of Geriatric Medicine Department at Jaslok Hospital in Mumbai. He is an elder care specialist. He has done MBBS and then MD in Geriatric Medicine. He was previously was working as an assistant professor at AIMS, Delhi. He has around 8 years of experience in this field. He has many publications. He has written a book chapter in an international renowned journal. He was a chief editor for Geriatric Updates published by ICGGM in 2018 and by IAG in 2016. He has been extensively involved in telemedicine for older adults for both COVID and non-COVID cases. He has been conducting support groups for older adults as a part of Graceful Living. Thank you so much for joining us today, sir. Floor is yours. Thank you.
Thank you. Thanks a lot for your introduction. Thanks a lot, ILC. I mean, you're doing some very good work as far as contributing to the education part for older adults and caregivers and, of course, professionals is concerned. So today I am going to talk about something which is very important because I think the bone health as well as even geriatrics goes really hand in hand, and that's where I think orthogeriatrics really comes in. I'm just yeah. So orthogeriatrics, as we call it. Globally, if we see hip fracture, unfortunately, is one of the most, you can say, among the top 10 causes of disability. I mean, this is by NEGM in 2017, must have only increased. And it is estimated by at least 2050, more than 50% of all osteoporotic fractures will occur in Asia. So, I mean, this was a substantiation or a probability which was done in 2011. And we already have had, unfortunately, 2.5 years of a pandemic. So you can imagine maybe the number of people who actually fell and had issues and could not even get surgeries done on time because there was obviously a delay in delivery for medical during this time, not because that was not the priority, but because of the obvious sort of pandemic we were going on. So historically, I think orthogeriatrics has a very big relevance. The first orthopedic and geriatric collaboration was done in Hastings in 1957, and Professor Michael DeVos, who was an orthopedic surgeon, and Dr. Bobby Irwin, who was a physician, did combined ward rounds. And this is, of course, through the courtesy of British Geriatric Society. So if you see in a lot of specialities, we have this concept of combined rounds, combined ward rounds, grand rounds. So these are all done so that various specialities can come together and give their specialized advice so that better care can be delivered to the older adults, in this particular case, orthopedics and geriatrics. Now, what is orthogeriatrics? Orthogeriatrics is basically a comprehensive interdisciplinary care in a geriatric ward, which is basically done so that it improves mobility, activities of daily living, which are the basic activities like moving, mobility, taking bath, then even going to the washroom, dressing. So these are activities of daily living and quality of life as compared to the usual care in an orthopedic ward. So it has seen, even through research, that when geriatrician and orthopedician actually work together, the results are much, much better as compared to the orthopedician doing things themselves. Now, there are 6 standards of orthogeriatric care which are very important. Now, all patients with hip fracture should be admitted to an acute orthopedic ward with at least 4 hours of presentation. All patients with hip fracture who are medically fit should have the surgery at least within 48 hours of admission and during normal working hours. Now, all patients with hip fracture should be assessed and cared for in view to minimizing the risk of developing a pressure ulcer. Now, this is so very important because pressure sores or pressure ulcers are so rampantly and they really destroy everything as far as a person who is lying down is concerned. Then All patients presenting with fragility fracture should be maintained on an orthopedic ward with routine access to orthogeriatric medical support from the time of admission. I think that is very important. From the time of admission itself, an orthogeriatric support is there. And all patients who are presenting with fragility fractures should be assessed for anti-resorptive therapy to prevent future osteoporotic fracture. So osteoporosis should always be taken into consideration immediately with a person presenting fractures. In fact, I would say even before that, purely because it helps in us obviously getting to know that what the bone health status is. If there is a fall, if there is a breaking of the bones, then we can treat them better. At least try to give some anti-resorptive therapy, which are various, which is includes a lot of agents like alendronate, denosumab, teriparatide. So a lot of them are there. And all patients presenting with fragility fracture following a fall should always be offered multidisciplinary assessment and intervention to prevent the future falls. I think that is very, very important. Now, models. Now, there are a lot of models of orthogeriatric care. One, of course, is the traditional orthopedic care in which the orthopedician will obviously admit and on a consultation basis might just call the other doctors. And orthogeriatric units in which there are beds which are combined, sort of taken care by both ortho and geriatrics. Then orthogeriatric liaison services in which, of course, joint admission is there and then both orthopedician and geriatrician will see. And then combined orthogeriatric care in which both take equal responsibility. Now, in orthogeriatric liaison, it might not necessarily be that the the geriatrician will admit, maybe the orthopedician will admit, and the geriatrician will only look up. Now, one of the most important things is what is the aim? The aim is to improve the care of acute hip fracture and fragility fractures in elderly patients through collaboration between an geriatrician and an orthopedician. Now, primarily, this should be to promote why? To promote the needs of the older person with trauma through the patient pathway and to ensure that they receive the same high standard of specialist nursing medical care within orthopedician services as they do with care of older people. So basically, an older patient is different than a younger patient because there might be other comorbidities like blood pressure, sugar, and maybe even asthma. These become the medical comorbidities. But apart from that, is there a cognitive impairment? Is there a history of fall? What is the bone health? And is there a history of urinary incontinence? Is there a history of repeated admissions? What are the drugs that the person is on? I think these all matter a lot. So, in making a detailed sort of joint plan, which will help in improving the overall care of the older adult. Now, as far as pre-operative care is concerned, I think it's very important that timing of the surgery, then what antibiotic prophylaxis should be given. This can be, of course, decided by the surgeons or might be jointly. Then venous thromboembolism prophylaxis, which most orthopedicians give anyways, very important and something which really bothers us pre-op and even post-op, which I'll come to, is fluid and electrolyte balance, which can be really sort of affected to a great extent. Then oxygen therapy. I think oxygen therapy, if needed, anesthetic management. Yes, a pre-operative care, always an anesthesia person will see and witness will be given. If there is any amount of traction which has to be sort of given, and pain, I think pain relief is so important because the amount of pain that an older adult will be because of the fall or because of the fracture which has happened might really instigate them or maybe even put them into delirium pre-op. Delirium prevention is more important because we have seen a lot of older patients after operations go into delirium. That is, so delirium is known as a acute confusional state. So it becomes difficult for us to manage. And then ultimately, even after post-op, if you really see, our target is to, after the surgery is done, is to start physiotherapy and to get them walking as soon as possible. But when delirium occurs, it becomes very difficult, and then we have to then look at the cause for delirium and make sure that whether it's not fluid electrolyte imbalance or whether it's an infection, so that most bases are covered. Now, as far as usually within 20 minutes, ideally, I would say the first contact with geriatrician should be over. Why? Because a baseline assessment of that older adult will be done. Then within 4 hours, ideally clinical assessment, which includes history, vitals, examinations, assessing for other injuries and medical conditions is very important. I think X-ray hip and pelvis should be done definitely within the first hour, and routine bloods including the glucose, urine routine, blood grouping, ECG, of course, preoperative chest X-ray, complete blood count, renal function tests, electrolytes, PT&R, etc. need to be readied. Then MRI scan of the hip, of course, if needed, should be done. This, of course, would be under the joint discretion or under the decision, of course, the orthopedist. Now, pressure relieving mattress should always be used because prevention of bed sores is more important rather than the patient having it and then treating them. And pain relief, I think, is very, very important. Now, pain relief could be seen according to the WHO ladder, depending upon the visual analog scale, usually where the scale is in a scale of 1 to 10, what is how severe the pain is. Then immediate fluid resuscitation with, of course, IV saline. The patient should be transferred to a bed on the orthopedic ward without further delay. Then within 12 hours, ideally full clinical evaluation should have been done, which includes history, drug review, neurological examination, social history assessment, then a geriatric assessment, which is highly important. Then as we continue, a pain management is important, fluids electrolyte management important, blood transfusion if needed should be ready, anticoagulation optimization, yes, should be done. Echocardiographic assessment if required should also be prepared before. Then within 48 hours, all patients with hip fracture who are medically fit should be done. And I mean, assess 48 hours of admission, that is 2 days, the surgery should be done. Now, post-operative management, I think, is one of the most important things and something which really bothers a lot of surgeons, and it becomes quite a bit of a headache for a geriatrician. Now, pain control is highly essential. Now, in the case of older adults, not always NSAIDs can be given purely because if there is already a present renal issues, then it becomes quite difficult. Now, and plain paracetamol might not always be ideal because the pain might be there. So maybe even non-opioids have to be used. And sometimes if the pain becomes really sort of painful, then of course opioids. But we have to be very careful about uh, the fact that there could be a chance of constipation, especially with opioids. And of course, if at all any single shot NSAIDs are to be used, be very careful. And prevention and management, I think, of post-operative delirium, yes, see if there is any infection, see if the electrolytes are fine, the fluid balance is fine, because depending upon that, only the management of post-operative delirium can be done as quickly as possible. If the older adult does not need to be in an ICU immediately after surgery, they should be got out. Even in the ICU, ideally, they should have a bed near the maybe near the window so that they actually know whether it's day or night. And there has to be a constant stimulation for them to at least know that who are they and who have been they taken care of by. For example, even try to maintain a single staff, maybe a 12-hourly staff or a staff who's constant, or all staffs who should be managing that particular patient should have the name so that at least they can recognize who's trying to take care of them. Then blood transfusion, if needed, yes, should be given. Wound care, I think, becomes very important. Yes, this will always be done from the orthopedician side, and if needed, joint care, yes. Pressure ulcer evaluation and prevention is very important. We should not need to evaluate it afterwards. So in this, we have to maintain an air mattress if needed, keep changing the position every 1 hourly. Then good nutrition, I think, is very important. High protein diet and early mobilization. Now, the early the mobilization, the more successful is obviously the surgery will be. A post-op antibiotic, of course, as protocol or as needed. Thromboprophylaxis is very important. PVT pumps and anticoagulation, we have to judge on case-to-case basis, whereas risk as benefit ratio purely because sometimes bleeding can occur, especially in older adults. Nutrition management, yes, a basic nutrition can be done, but the help, as we know that usually geriatrics is about a multidisciplinary intervention, so a dietitian can be involved in giving that particular perfect diet, which all not only helps in taking care of the older adult in a holistic way, but also making sure that bed sores are also prevented. Now, two things which are very distressing for an older adult and which can cause delirium also include urinary retention and constipation. So it's very important for us to know if the person is on urinary catheter, when we can remove it, and if there is urinary retention, what is the cause. If not really needed, we shouldn't always try to recatheterize the patient after giving. We can do temporary catheterization so that we can see that at least the urine is taken out rather than putting a catheter in and then trying to induce any infection. Constipation should be taken care, especially if mobility is increased and food is obviously improved, then constipation might improve on its own, or if not, then we might have to give certain solutions or maybe oral when the person starts so that the constipation obviously goes. Now, very important in an orthogeriatric case is that early mobilization and rehabilitation, especially with a physiotherapist. Now, the first target is to sit the patient out of bed, then to begin to stand them on the day after surgery. That is ideal. And then slowly and steadily improving the walking. That's why they say, when we say for most people who maybe undergo a hip fracture and surgery, the real task is after the surgery and after the physiotherapy actually has to start, because that is when the older patient has to really take a lot of effort. Now, weight bearing is also very important. So, with the help, of course, of the orthopedician and the physiotherapist, we will be able to take that decision. Now, prior to discharge, it's very, very important that secondary prevention of fracture is done. So, all patients presenting a fragility fracture should be ideally assessed for the need for anti-resorptive therapy, especially to prevent future osteoporotic fractures. Now, this includes, of course, a DEXA scan and a clinical scores assessment. Now, FRAX is one. So, DEXA scan will be helpful. Unfortunately, not all hospital setups have DEXA scan, but it's good to know what is the bone mineral density so that we can start the patient already on anti-disruptive therapy so that we know that the next fracture should not happen. Now, post fracture falls assessment is also very, very important. Now, all patients who present with any fragility fracture following a fall should always be offered multidisciplinary assessment to have a falls assessment, not only to know the current reason for the fall, but also to prevent future falls. Remember, prevention is most important. Treating falls is not always easy because it might have invariably led to some fractures. Now, interventions to reduce falls have been found to be very, very useful. These include multifactorial interventions, professionally directed and individualized, I think, balance and strength rehabilitations. That's why the physiotherapist might also come in strongly. Then professionally led home hazard and remediation. I think this is very important. Home hazard assessment sometimes is not done. Now, home is always told to be very safe in general, but no, home is where the maximum amount of falls take place. So whether it's the height of the toilet or the lack of grab bars or the surface of the toilet or the home or which floor they are living, we need to know so that all the hazards are removed. Then exercise and extended care settings. Yes, exercise will have to be done. Then psychotropic medication withdrawal. This is very important because more psychotropic medications are there for a higher amount of time. There's a greater chance of them being drowsy or having any other issues and then ultimately falling. Now, lot of causes are there. For example, syncope. There could be rhythm. There could be rhythm disorders. So cardiac pacemakers, for example, for carotid sinus hyperactivity or for the other rhythm disorders might be needed, especially who have experienced unexplained falls. And just putting a pacemaker always helps. Now, one of the most important things about orthogeriatrics is also to educate and inform both the patient and the caregiver regarding fragility fractures, regarding the fact that how important bone health is. And this is what would help in both the patient, the caregiver, and us as a team to make sure that further falls are prevented. So here, orthogeriatrics, the real big main point that starts is usually a fall, which usually causes it. But a lot of times fragility fractures might also occur. As I said, osteoporotic fractures, especially of the spine, what you will see is just a reduction in the height of the older adult. Until and unless the fractures are so bad and they are painful, you might not even able to know that there is actually a fracture. So the close assessment, especially doing physical assessment and doing x-rays, especially of the spine, and if needed, the MRIs also during routine checkup might be warranted. Now, what are the real targets of the orthogeriatric service? Now, one of the most important targets, yes, is perioperative medical management. Now, we need to know, identify, and treat what acute issues might actually be there for the patient, especially for surgical intervention. Just before that, treat the acute medical illness, optimize the patient, get them ready for surgical intervention. Then they advise on complicated issues, especially on fluid imbalance, balance, and the avoidance and the treatment of medical complications of surgery. I think that is what is very important. So the first and strongest point is perioperative medical management. Then, to ensure once the patient is medically fit, they are operated within 24 hours by a surgeon anesthetist whose competency matches the complexity of the patient, and an appropriate level of post-operative care is available. Now, the thing is, as I said earlier, within 48 hours, but that doesn't mean that you can't do it within 24 hours. My only question here is, we as geriatricians have to make sure that we are able to give them that confidence that the person is medically stable enough for them to go ahead with surgery. Then I think to ensure the pain management is effective and safe, I think pain is very, very important. There will be post-operative pain as well. So pain management in orthogeriatrics is very important, and once that is taken care good in a good way, and the results of surgery or preparing them for surgery becomes easy. Now, psychiatric illness has also shown to be what is known as a poor predictor, especially for hip fracture, and the cognitive function should be assessed routinely on admission. So, identification of the 3 Ds, that is depression, delirium, dementia, and also alcohol misuse should be done. And if needed, maybe even psychiatry of old age can be sought out. Now, one of the most important things is to carry out a multidisciplinary falls assessment with link to fall services. So, fall clinic also helps, and rationalization of all the medications that the older adult has, because to a great extent, the medications can be the one which might be contributing to the falls, and it is our responsibility then to make sure that we are able to take out those medications at least, so that one needs to know that these medications might be the one which might be making them drowsy, or these medications are the one which will ultimately might lead to future falls. Now, all patients with low trauma fractures also should be assessed for osteoporosis. So you should not think that only a patient who has fallen, who actually has had a hip fracture, are the ones which, I mean, who is having a significant trauma, only those should be assessed. No, low trauma fracture should be assessed, or other causes of pathological fracture, especially cancer and other issues, which could be secondary causes of fracture, and treatment should be prescribed. Now, it's very, very important that in orthogeriatrics that we promote the discharge planning from the point of admission. So this can be done, of course, through proper community services liaison, and of course with multidisciplinary team and carers, with taking into account the patient's wishes. I think that is very, very important. But yeah, because usually in orthogeriatrics there is so much of experience between both, we are able to decide, yes, this could be the probable point of exit or discharge of the particular patient. Now, to ensure patient having a maximize their rehabilitation potential, I think this is so important that in the hospital and the community environment, we are able to get the rehabilitation to the maximum, so that ultimately they can return to their previous place of residence, and hopefully at that pre-surgical level wherein they were independent, or their pre-fall level or the pre-fracture level where they were more independent as compared to post-surgical. Now, I think another important thing where geriatrics will play a very important role in orthogeriatrics is to advise on complex ethical issues, including end-of-life care and CPR. I think that is important. The role of advance directive is important. Unfortunately, it is not very, very commonly used in India because it doesn't really have a legal standing. Then another important thing is to be involved in morbidity and mortality review with the orthopedic and anesthetic teams. I think it helps us in knowing, if at all, what mistakes had happened or what could be bettered. I think meetings of multidisciplinary units always help in us to know what could have been done better. Then to be involved in training and audit together for the development of evidence-based pathways and guidelines. I think that is very important, because ultimately whatever patients we see uh, as joint, we have to know how much of a difference we have been able to do for that particular patients, and also what can be improved so that we are able to develop better guidelines in order to help treating them better or treating the future patients. So if you see overview of the orthogeriatric model, ideally, if the person comes to any trauma center or any hospital, first contact ideally should be with the geriatrician admitted in orthogeriatric ward for pre-op care. Then, of course, with the help of orthopedician surgeons, operated post-op care again in that common ward. Then discharge and follow up in a fragility clinic. So ideally, there should be a fragility clinic in which the orthopedician and the geriatrician can actually see them together so that they can have a joint views on how to go ahead with them so that a better care can be provided. So overall, orthogeriatrics is the best, you can say one of the best forms and the need of the hour in which better care can be given for patients, especially for patients with fragility fractures and of course hip fractures being one of the most common ones, so that the overall outcome of doing the surgery also sort of improves and one of the and lot of medical issues which an older adult might actually encounter can be taken care of in a better way. Thank you. Thanks a lot for your patient hearing. And as I always tell all older adults, this is what we should always profess. Come grow old with me. The best is yet to come. Thank you. This is, of course, my contact details. And I also have a Facebook page in which I keep trying to educate older adults and caregivers. Thank you. Thanks a lot.
Okay. Much. Now the floor is open for the questions. Please ask questions, raise hands, let me know. Any questions, any comments also? We are welcoming comments.
I think there's already one
question. Okay. Shigli ma'am, want to say something?
Nice presentation. This interdisciplinary working is actually, or interprofessional working is the need of the hour. Because as you mentioned initially regarding the, you mentioned regarding the caregivers, isn't it? But because what I feel the level of education is very low, that's what I feel, what the literature says. Ultimately, we need to even address those who are caring for these older patients, because at that point of time, the awareness of the family member or these professionals who are near to them that actually. So thank you for addressing this important topic.
Sir, I have a question. At exactly what stage the physiotherapy is important? Because in many of the cases that I've seen, so a post operation with this geriatric person, the doctor does not take that kind of risk, and they do not actually go for this physiotherapy session. And later they say, oh, because that it at that time it was not initiated, so now there is no use. So how do you deal with such issue?
No, I would say that as soon as the surgeon obviously, I mean, operates and the geriatrician might also be involved. Usually, in most cases, every orthopedician wants to get the person back on their feet or at least try physiotherapy within 24 hours or the next day of the operation. I mean, that's the reason why the operation is done as well. Now, of course, this is why the post-op complications are very important. So, for example, if there is a delirium or if there is a post-op infection, then everything automatically gets delayed. So in that case, of course, there will be a delay. But ideally, yes, I think the physiotherapist should always, along with, of course, the orthopedician, uh, should try to assess what can be done. So it should be a joint effort only, not only the fact that there should be only one thought process that it shouldn't be done. Because sometimes what happens is, I have also seen, I mean, even in I'm not even talking about fragility fractures, that has been seen that even after replacement, I mean, what you're only replacing is, I mean, just, I mean, changing the old joint with a new joint, but that doesn't change anything. You still have to do physiotherapy so that you can start those joints to move properly.
Right.
And sometimes that point is really missed, especially with patients, because they feel that once the transplant is done, everything is over. But that's not the case because we are dealing with people. For example, there are very tough cases in which people are still very sort of have a huge weight. The only thing which has changed is the knees, but then they still need to continue to obviously try to walk. And any amount of inertia that happens at that level, really, because once the muscle is started to degenerate, and even if you have new joints, it doesn't really make much of a difference. I mean, and I have seen this is, and this is unfortunately not a failure of the orthopedician. It is the failure of the fact that the post-op period in which the adequate motivation was not maybe given, or
Right.
the patient was not motivated enough. Sometimes they just
Yes.
don't want to do it. So that becomes sort of an issue.
Yes, sir. Thank you.
Yashoda, there are a few
Yes.
questions from Dr. Mahesh Hemadri
Yes. Himadri,
in the
sir.
chat box.
Yeah, it's there in
Yes.
the chat
Yes.
box actually. Yeah, so
Actually, yeah.
whenever elderly undergoes surgery under GA, what post-op follow-up one has to do? Keep in mind days, weeks, monthly. I think this is too, I mean, to be very frank, too huge a question. But what I would say is ultimately it depends on the type of surgery. Let us not generalize it. But there have been, if for example, I'll just give an example of maybe uh, inguinal hernia. So after the hernia surgery, usually, I mean, I have seen the surgeons just, especially if it is done. So these days, everything is done through endoscopically only, and it's offered as well. So the next day, the patient is even discharged, and the follow-up usually the surgeon does is usually after one week, and then obviously they have to look at the sutures, and then later it will be done. Now, as far as medical conditions are concerned, if the person obviously has medical conditions, I would also want to see that patient at least after 1 week, and then later to assess whether if there's sugar, blood pressure, which has been controlled. And then, of course, depending upon when the surgeon calls, I would be okay seeing that particular person even after a month. The complicated surgery, then everything changes. Especially, I mean, if it is a CABG or it's a hip surgery, then everything will change purely because the patient might still be discharged, but the follow-up will be really strong, especially at home also by physiotherapy, wherein we'll have to see if the person is actually moving or not, and that will be sort of really difficult. Then, what are the different medications that can be administered through epidural route for post-op pain? Of course, I mean, to be very frank, usually when we would come into the picture, uh, a lot of anesthesia, I mean, anesthesia will already be involved, and that would have already been given. But I mean, it varies. I mean, the number of anesthetics are so much, so we have to see which which medication will be specific for that particular patient's profile. For example, I mean, if the person has a kidney problem, then even giving I mean, anesthetics might be an issue because they might not come out of it at all. So first, of course, we will wait. I would not really want to go into the epidural route at all once the post-op pain, I mean, once the anesthesia wears out. We these days can even, luckily, we are also blessed with patches these days. So even going for patches is something which is really good. And patches are something which can be changed within 24 hours or 48 hours. And that helps an older adult much more. It is, yes, more expensive. We have to obviously take into consideration cost as well. If oral medications cannot give, then I think patches are one. And then, of course, short, I think short acting analgesics are something which can be given. Now we are actually luckily in a situation where throughout India there is also something known as transition care, in which people actually get discharged, and at home that post-op care can also be done. So that also has been done nowadays, and I think that is something which might we even see in the future. I mean, even ICUs have been set up at home now, especially during the COVID era as well, and before that also for long-standing lung conditions which have been sort of there. So I think it will entirely depend, but pain has to be taken care well. And of course, the orthopedic follow-up, in which, depending upon the surgery, whether obviously they will want to know whether the union has actually taken place properly. And one of the most important things is, I think, anti-resorptive therapy, which should be concentrated on. It doesn't mean that after the surgery is done, the bone becomes strong. No, the bone does not become strong. So we need to continue working on it, whether it's any molecule which the older person is okay with, whether it's vitamin D or whether it's going to be alendronate. We need to sort of obviously discuss with the older adult and the caregiver, and of course try to start it, because we need to make sure that the bones are still remaining strong. because whoever has one fall is always having a risk of another fall. So there is no two ways about it. And I think, as earlier asked, the most important period in orthogeriatrics is actually the post-op period after the surgery is done, because sometimes everything can go good, but up in the post-op period, electrolyte disturbances can happen, delirium can happen. That is the medical part. In the non-medical part, again, the person is building confidence to walk. To motivate them, a fall can happen at that time also. So I think that's why the bone health continues to be. So as I had mentioned, that they should always follow up in that fragility clinic, which will be jointly seen, so that the orthopedician is also happy and the geriatrician is also happy. Yet, yes, medically we have been able to take care of this, and surgically this is what I want, or this is what we have to do, and the physiotherapist can obviously continue the work. uh, Now another important thing, which is very important, I think, in general also, is when we assess, as far as assessment is concerned, we should also see the cause of fall. A lot of times it's not the bone health which is responsible. It is as trivial, I will say trivial. Why? Because it's easily missed. The footwear that the older adult wears, I mean, that is always missed. Nobody checks, nobody tries to check that. Then foot deformities, I think, are very, very important. A lot of people have rheumatoid arthritis in which they have had deformities, feet deformities. A lot of people have had small minor fractures in which there is just a deformity. For example, the big toe goes like this and it does not go through the slippers. So these things have to be seen immediately, as the person even walks into our clinics or in the hospital, because these are some things which can be modified almost immediately. Then of course, people with diabetes might have neuropathy, so that is something which is always liable to fall. So the type of footwear becomes important. So the use of buckles, use of straps are more, because if the normal slippers or chappals will be put, then they will be easily, I mean, one of the most common symptoms are supposed to be slippage of slippers, which happens with neuropathy, but that will not happen, especially in an older adult who is given those sort of foot. So the importance of getting that orthototic also is very, very important, that we are able to get the proper shoe, the proper footwear also. Again, very neglected. It's always a medical cause that we think, but this is a part of the body. So it is a medical cause. Anything in a part of an older adult is a medical cause. Then I think home hazards, which I have mentioned, should always be taken care of. Very easily neglected, lack of light. Then urinary incontinence. A lot of older adults fall in their own urine, and they are just slip and fall in their own urine. And I think even cardiac disabilities, which I really sort of mentioned, because any amount of, if you have a rhythm disorder, then the person can just go into syncope, and depending upon where they are, people have fallen on the road also because they suddenly, I mean, that is not even under their control. Then orthostatic hypotension is another, where you have blood pressure different in different levels, and if anybody has vertigo. So these are a lot of causes, but not all causes are medical. That's what I'm trying to highlight. Never neglect or forget the other ones. I think we have another question from Nazreen, ma'am. I think diabetes affects the food. Any suggestions? I have actually partly answered it. But what I would say, the biggest thing is, I think we have to take care of, one is the sugar. Of course, the sugar has to be kept under control. It is a misnomer thinking that no, he or she is already a diabetic, the feet are already affected, so that neuropathy will just continue to go. No, the levels of neuropathy are also there. Though if you actually control the neuropathy, there is a greater chance that at least the numbness might decrease, if not completely go. That is one. Secondly, of course, I think the most important thing is footwear. See what abnormalities have actually happened. The presence of peripheral vascular disease is also very important, because a lot of times we have seen patients with diabetes are not even able to know that they have got hurt. And we see these fungating bad ulcers, which might ultimately lead to amputations. Now, when a person is also amputated, I think it's very, very important to give them that artificial limb. Very difficult to convince an older adult for the amputation. One. Secondly, it's more difficult even to convince them to get the artificial limb, but it is only improving their quality of life. I think that is one of the very, very important things. So I think strict diabetic control, but at the same time, by strict, I mean it shouldn't go low. I'm still happy with it being at some level, maybe anything below 200, I'm still comfortable. But if any time it becomes 100, because hypoglycemia is another cause, very, very simple cause of fall in which a person might get it anytime and the person might just fall off. And in background, I will again stress prevention of fall is very important. But once the fall is happening, if the bones are at least stronger, there is a strong chance that the fractures might not happen. Because if somebody just slips off and falls, it's not necessary always they will have fracture, or in hypoglycemia you'll just fall off like a drop attack. But if you have bad bones, weak bones, then that is enough. That is enough for somebody to actually just get, I mean, and fractures can happen anywhere. One of the very difficult things to actually treat is rib fractures, because they do not have a particular treatment, because you have to wait for the self healing, and sometimes you just have to put those apparatuses to make sure that the chest is the person is very comfortable. Of course, if there is a major rib issue and organs are involved and it's open up, then of course surgery will have to be done. So I think this in overall, I've also covered Nazreen ma'am's question, I think. But the baseline is long-term care is important. You have to make sure not only taking care of post-op, but make sure that the bones are very strong throughout, so that the next fracture or the next impending fall does not cause as much damage, and hoping that there should not have, I mean, another fall does not happen. Social issues also are very important in this. Who is going to be the caretaker? Who is going to support them? Is the person alone? Then what is the caregiver support? The need for a trained caregiver. I think that is also important. The person who does not have a caregiver, they should be provided home physiotherapy, because not always these older adults who post surgery will be able to come to the hospital and do. I mean, it's easier said and done. I mean, COVID has been a blessing in that way, that at least home services have also sort of become more improved, because more people have reached out home as well. So I think that is another way in which a baseline can be maintained, and multidisciplinary coordination between the physiotherapist, the geriatrician, or orthopedician can help in improving the person even at home, even after that particular post-op period has uh, actually lapsed.
Yes. So just small question. There are hip kind of belts, belts around the hip and that deploys into the airbag and they prevent kind of fracture. So do you believe in them first of all? And if why do you think they are not in the practice of senior citizens yet?
You mean hip protectors?
Yes, hip protectors.
Hip protectors, because the evidence is very mixed. Now, the thing is, hip protectors only prevent the fracture from happening. They do not prevent the fall. So I
Right,
think I
right.
think both are very, very different. And it's mixed in results. It's saying people with hip protectors might also ultimately, depending upon the impact, there might be a fracture inside as well in that particular movement only, and the person might obviously have a fracture. But it does nothing to bone health, or it does nothing to actually the prevention of the fall overall. So it is not really, that's why it's not really encouraged a lot,
Right, right.
because it
It's
in the
not even
bigger
seen.
picture it doesn't prevent falls, or it doesn't improve bone health, which are, I think, one of the two most important things for hopefully making sure that an
Right,
older adult
right.
does not get. Another thing, I mean, since you mentioned this, it has been seen that people who are heavier, that is more obese, have a greater chance of protection from fractures because of the obviously body fat, But make no mistake, if there is a fracture, then the recovery is worse. So it's not a generalized statement that we can make, that just because somebody's, because the protection will be there. Yes, research says that the
To
chance
some
of
extent,
fracture might be
yes.
less, but
Hmm,
if there
hmm.
is a fracture, then recovery is very difficult, because you are talking about huge weight bearing on that particular organ, I mean, on the particular bone, even after repairing.
Right. Yes, thank you, sir. Anjali, ma'am, yes.
Yeah, I just wanted to ask, you spoke about post-operative management and you mentioned weight bearing. Could you just let us know what exactly you meant by that?
Yeah, by weight bearing, I mean ultimately once, for example, the hip fracture is, I mean, the surgery is done. So slowly and steadily, along with the physiotherapist, we try to make obviously the sitting part, the standing part, and then we have to see on that particular leg how much amount of weight bearing can be done. So like slowly and steadily, that particular person can walk properly. Now here we have to decide how much external support might be needed for that particular weight bearing. For example, if the weight bearing is with the help of a walker, so in which the weight will be distributed. It usually cannot be done only with a stick, because then what will happen is if the sort of the joint is still unstable, then that weight bearing which we have given an attempt might be a bit difficult. So usually it's to assess whether how much amount of time can be given for that particular post operative joint to actually start normal weight bearing of the body. So we try to obviously slowly and steadily do, so that the normal walk can be reached in some time.
Thank you.
Okay. Ma'am, you want to conclude something?
Yes, before we conclude this session, I'd like to say that we've received a world of information on this topic. Obviously, this topic is growing. Orthogeriatrics is a kind of a new novel topic that has come in, and I think it's very important that we always have geriatricians as we speak about multidisciplinary approach to treatment, and having specialized geriatricians in every field, every medical field would be a great advantage, as it is seen over here. You gave us a lot of information about, details about hip fracture, like, which I personally didn't know, that, you have to get operated within 48 hours, or, you have to go to the hospital within 4 hours. I mean, those little tiny points of information which would help every common man, say, to speed up the process for having a better recovery chance for the older person. And most importantly, you also spoke about how there are other reasons other than medical causes that can cause a fall, like simple things like bad footwear or some kind of a foot deformity. I think that we need to, when we are looking at our taking care of older relatives in our house, we need to understand that and watch out for these things, whether they have good footwear, or is there a problem with their feet, or those things. So besides the medical causes, we do have certain other reasons that can lead to a fall. So I think that was very important. And as I said, having a multidisciplinary approach in this field, because a geriatrician also looks, I think, please correct me if I'm wrong, he also looks into the mental health of the older person.
Yeah,
You need to, when you're treating an older person, you need to treat him differently from a younger adult, because there are certain other issues at work, at the mental level, emotional issues that possibly they're alone, they're living by themselves, or they've lost a spouse. This I'm talking in general of how a geriatrician would understand this, rather than just an orthopedician, or any other medical doctor. So I think this combination would work best. And you're doing a great job. We're really happy to have had you here for this session. And we look forward to a close association with you in enlightening the common man about how we can prevent falls, what should be done if at all there is unfortunately a fall. You've given us a lot of information. Thank you, Dr. Narasimhan.
thank you.
Yashoda?
Yes, thank you, Dr. Narasimhan, for being here, and thank you to all the participants for being here and contributing to today's session. We are looking forward to your support. So I want to thank our sponsors, Gharda Chemicals Ltd, for their support, and thank you, team. See you. And this session is available on YouTube. So even if your friends are not able to watch today or join us today, then please share the link. Even to Dr. Narasimhan, if your any of the colleagues they want to see this lecture, please ask them to visit our YouTube channel. The session is there. Okay. Thank you. See you. Good day. Bye.
Bye.
Thank you.